Okay, let's dive into our roadmap for today. We're going to hit the classification, then management, grab a key clinical pearl, dodge a classic exam trap, and wrap the whole thing up with a quick recall question.
All right, first up, classification.
Now, looking at this, it's basically like climbing a tree. The biliary tree, that is. Notice how the problem progresses logically as we go up. We start at the bottom with type 1. This is a stricture of the common hepatic duct that is greater than 2 centimeters below the hepatic duct confluence. It's a low stricture. Then we inch up a bit for type 2. The stricture is now less than 2 centimeters below the confluence. See how it builds? In type 3, the stricture actually hits the hepatic duct confluence. But, and this is key, the right and left hepatic ducts are totally uninvolved. Now things get a lot trickier in type 4, where the stricture involves the confluence plus both the right and left hepatic ducts. Finally, we have the wild card, type V, which involves an aberrant right hepatic duct, and that can happen with or without common hepatic duct involvement.
Let's actually turn that table into a rhythm to really anchor it in your memory. Just say this sequence with me step by step. Step 1, low stricture. That's type I. Step 2, near confluence, type 2. Step 3, confluence, type 3. Step 4, both hepatic ducts, type 4. And step 5, aberrant right hepatic duct, type 5. Low, near, confluence, both, aberrant. If you repeat that rhythm a few times, you're literally going to intuitively lock in these definitions.
Moving right along to management. Before we start talking about specific procedures, we need to know what our actual goal is. In managing any of these benign strictures, the objective is incredibly simple: restore durable bile drainage. That is our guiding North Star.
So how do we pull that off? Well, we tailor our approach right to the stricture type. For types I and II, because the stricture is lower and leaves us with some healthy common hepatic duct to work with, they're usually perfectly amenable to standard biliary reconstruction. The most common approach you'll see here is a Roux-en-Y hepatojejunostomy. Now, for type 3, because the confluence itself is involved, the reconstruction has to be done much closer to the hilar ducts. Type 4, that's where it steps up the difficulty significantly. Both the right and left hepatic ducts are involved here, which requires complex hilar reconstruction. Honestly, sometimes you even need to create completely separate ductal anastomoses for the right and left sides. Finally, for type V, the management totally depends on the specific anatomy and drainage territory of that aberrant duct. Basically, the higher the stricture goes, the more complex the plumbing gets.
All right, time for a key clinical pearl. So the absolute crucial point that you need to take away is that this entire Bismuth classification system is built on exactly 2 variables. It's all defined by the distance from the hepatic duct confluence and the involvement of the right and left hepatic ducts. That's it. Are you more than 2 centimeters away? Less than 2? Does it touch the confluence? Are the right and left branches involved? If you know these 2 variables, you can instantly categorize any benign biliary stricture.
Okay, watch out for this classic exam trap. Seriously, lean in for this one, because this is exactly where test writers will try to trick you. On the left, we have the Bismuth classification, which is strictly for benign or iatrogenic biliary strictures, like a tricky cholecystectomy gone wrong. That's what we've been covering today. But on the right, we have the Bismuth correlate classification. Notice that added last name? The Bismuth correlate system is used specifically for perihilar cholangiocarcinoma, which, of course, is a malignancy. Do not mix these 2 up on test day. Benign stricture, use Bismuth. Tumor, it's Bismuth correlate.
Let's wrap things up with a quick recall question. All right, here's your scenario. You're looking at a benign biliary stricture that involves the hepatic duct confluence, and it extends into both the right and left hepatic ducts. Think back to those visual anchors we talked about earlier. What bismuth type is this? Boom, you got it. That is bismuth type 4. Remember our little sequence? Low, near, confluence, both. Both ducts involved means type 4 for sure. Mastering these structural landmarks makes a really complex biliary tree so much easier to navigate. So the next time you're scrubbing into a complicated biliary case, ask yourself, do you know exactly where you are anatomically, or are you just 1 millimeter away from turning a routine fix into a total surgical disaster? Keep this explainer handy for your rapid revision, and I'll catch you on the next one.